Even though I've just joined the faculty 6 months ago, I'm not new to Loma Linda, having graduated here with my PhD from the Department of Psychology. In fact, during my time as a graduate student in 2006, I was actually part of the team that collected the data for the Adventist Health Study in 2006 and 2007. And so I would say that was about the time that I became interested in the lifestyle practices that help to promote healthy aging. And not being new to Loma Linda or the Adventist community, I know that Loma Linda has a long time been an advocate of lifestyle factors in promoting healthy living. And what's so exciting is that the neuroscience research just in the past 10 years have started to provide support for the evidence supporting lifestyle factors and lifestyle choices in maintaining cognitive health into older age. And so I'm going to discuss what that literature has entailed. And then we're going to end with some memory training practices that all of us can use in our daily life, regardless of age. So we know that people are living longer, and as people live longer, medical communities and society at large is confronted with the disease profiles that are associated with aging. Now, one of those disease profiles is that of dementia. Dementia is an umbrella term that is used to describe the cognitive impairment that is associated with various disorders, most which are neurodegenerative disorders, of which Alzheimer's disease is the most common. Now, if we think of dementia as a whole pie, there are various etiologies or causes of dementia, but Alzheimer's disease is the most common form or the common cause of dementia. And you can think of Alzheimer's disease as taking half of that pie. There are various risk factors for Alzheimer's disease, but age is actually one of the highest risk factors for Alzheimer's disease. You can see that this data was actually just published last year by the Alzheimer's Disease Association. And you can see that age is the biggest risk factor specifically for that 75 to 84 age group. And it continues into the 85 plus age group. So age is one of the highest risk factors of Alzheimer's disease. Now, just with normal, healthy aging individuals who don't have any risk for dementia, there is simply a change that takes place. And this is just simply termed as normal changes that occur with the aging process. Now, starting at age 40, there are simple declines that start to occur in the brain. And our attention declines slightly, our processing speed declines slightly, the ability to retrieve information or verbal recall declines and slows down a little bit, and our ability to mentally shift our attention between tasks and multitasks also slightly declines about a little bit every decade. Now, these declines have been associated with just normal changes that occur in the brain, such as the changes in the cortical structures of the hippocampus and the entorhinal cortex, and also the subcortical structures of that white matter in the prefrontal regions. The prefrontal regions of the brain are important for processing speed and is also important for the connectivity between the brain regions. And so this becomes a little bit less efficient with aging. But then again, if all of us can think about our years in our 20s and our 30s, we can just probably observe just a little bit decline in our processing speed and our slower ability to recall names and information just with every decade. So some of that is going to be normal. With Alzheimer's disease, there's going to be an accelerated decline in all these abilities that we just discussed. And this has been associated with pathological changes that occur in the brain, mostly with, you've heard of the beta amyloid plaques, which are the abnormal proteins. You've probably heard of tau tangles. These two together actually are the primary biomarkers of Alzheimer's disease. And in the case of Alzheimer's disease, there's been advancement in neuroimaging techniques and cerebrospinal fluid testing that have actually found the presence of these biomarkers in an individual for at least a decade before their cognitive decline starts to occur. So this has led researchers to understand that individuals may be coping with these pathological changes at least a decade or more before it's observed in that individual's behavior. This has also led researchers to come up with a theory of cognitive reserve, that the brain has a capacity to buffer against atrophy and delay the onset of functional decline that is associated with Alzheimer's disease. And in other words, there can be lifestyle factors that can work as protective measures for that individual so that they can increase their threshold and deal with these pathological changes that occur in their brain and protect it and delay the onset of memory decline before it starts to affect their memory and their functional decline. So I'm going to talk about the studies that support the theory of cognitive reserve using neuroimaging findings as an outcome measure. Now you'll see these MRI slides are just for demonstration purposes only. The one on the left is an MRI of a healthy individual who has not been diagnosed with Alzheimer's disease. So this is what a normal healthy brain should look like. You can see the red is the hippocampal structures. The blue below it is the entorhinal cortex. And if you can contrast this image to the image on the right, where there has been significant atrophy in the hippocampus and in the entorhinal cortex. And this atrophy then leads to that enlarged sulcal, that enlarged ventricle space that you see. And this is to the right, of course, is an individual who has been diagnosed with Alzheimer's disease. So you can see the significant change in the person's brain when they are affected with Alzheimer's disease. The reason why the hippocampus is important is because we know it to be the area of the brain that is important for the development of new memories. And this is the area of the brain that is most and first impacted in an individual who has Alzheimer's disease. And so thus, a person with Alzheimer's disease has an impaired ability to develop new memories, and thus we understand them to have deficits in short-term memory. So the interesting studies that have been found to support cognitive reserve have been about physical activities. These are in healthy adults who have no dementia. A cross-sectional study of seniors have been found that higher physical fitness has been significantly associated with a higher hippocampal volume on MRI. Now, physical fitness was assessed by treadmill exercise using peak oxygen consumption, and these findings were actually found after controlling for age, sex, and years of education. So the summary of this this finding is simply that having a higher physical fitness has been associated with a higher hippocampal volume among healthy seniors without dementia. The same researchers published another study a couple years later in which they randomly controlled in healthy seniors without dementia to either a intervention group that involved an aerobic exercise program for 1 year, or to a stretching control group in which there is no aerobic exercise but simple stretching exercises. And what they found was that the intervention group, or those who participated in this aerobic exercise, actually had an increase in their hippocampal volume by 2%. This was in contrast to the control group who had the stretching exercises. There was hippocampal decline found in the control group. However, this decline was attenuated by a higher pre-intervention fitness level. So if that individual had a high intervention fitness level, even though they were randomly assigned to the stretching group, they had less decline. The summary of this is that participating in a physical aerobic exercise routine seems to protect against hippocampal volume loss. And again, these findings are with healthy older adults who had no dementia. But the interesting thing is that we still see the benefits of physical activity and the importance of physical fitness even among older adults who have been diagnosed with early stage dementia due to Alzheimer's disease. Physical fitness was associated with greater preservation of whole brain volume and brain white matter, and this finding was independent of age and dementia severity. So again, even if that individual has already been diagnosed with early dementia due to Alzheimer's disease, they could still benefit from some sort of physical activity. Now I'm going to talk about the findings in support of cognitive reserve using cognitive functioning as the outcome measure. So this particular study found that among individuals who were diagnosed with early dementia due to Alzheimer's disease, physical fitness, which was actually just by simple walking, had a dose-dependent relationship with their cognitive functioning. And their cognitive functioning was measured using the MiniMental state exam. Now, if you're a physician, you're very familiar with the MiniMental state exam. If you're not a physician, the MiniMental state exam is a 5-minute screening of overall cognitive functioning. And what these researchers found, that these participants who had been diagnosed with early dementia due to Alzheimer's disease, those who were sedentary over the course of a year actually declined in their cognitive performances, while those who actually walked at least 1 hour on a weekly basis over the course of a year showed no decline. Compare this with those individuals who actually walked 2 hours or more on a weekly basis over the course of a year, actually improved in their cognitive performances. So again, even if individuals have been diagnosed with early dementia due to Alzheimer's disease, we're finding the benefits of physical exercise and lifestyle factors. Now, we've talked a lot so far about physical exercise, but what about cognitive activities? This particular research looks at cognitive activities in actually lowering the risk of dementia among older adults. Now, the cognitive activities that they studied that they examined included reading a newspaper, playing games such as chess or checkers, visiting a library, or attending a play. And what these researchers found that more frequent participation in these cognitive activities was associated with reduced incidence of dementia in old age. And these are, their participants had a mean age of 80. This was found after controlling for lifetime social economic status and current social and physical activity. So even above and beyond physical activity, participating in cognitive activities seemed to be just as important. What was interesting is that frequent cognitive activity was associated with reduced risk of mild cognitive impairment. Now, I've heard the previous speaker talk about mild cognitive impairment. Mild cognitive impairment has just been recognized in the past 10 years as being a risk category for dementia. These individuals showed slight declines in attention and memory and language abilities. They show a little bit slight declines compared to their same age peers, but they do not yet meet criteria for dementia at that time. However, people who are in that mild cognitive impairment risk category do have an increased risk for developing dementia later on. So it is important to identify individuals who are at this risk category. And the interesting thing about this research is that participating in cognitive activities on a frequent basis even reduced risk for mild cognitive impairment. Another study found that cognitive activities actually can delay the onset of memory decline in persons who eventually develop dementia. Now, this was actually part of the Bronx Aging Study, in which individuals were asked to rate or report their participation in one of 6 cognitive activities. And I have the cognitive activities listed here, which include reading, writing, doing crossword puzzles, doing board or card games, participating in group discussions, or playing music. And what these researchers found that each additional self-reported day of cognitive activity at baseline delayed the onset of memory decline by about 2.5 months. So if we added a whole week of participating in cognitive activities, that in itself could delay the onset of dementia in that individual for up to 1.5 years. And what was so interesting is that usually educational and social economic status are seen as protective factors. In this model, the researchers found that education and social economic status did not significantly change the fit of the model. So the bottom line of these studies indicate that participating in some sort of cognitive activity and staying mentally active, even in old age, really matters and can enhance cognitive reserve regardless or despite educational activity and social economic status. Now, I'm going to talk about the studies of cognitive interventions and cognitive training. Cognitive training and interventions are actually programs that are developed and that are offered and that provide a specific training in a specific domain. So whether they're memory enhancement training courses or whether they help to improve processing speed, there have been some sort of these programs that have been developed and that have been studied. The 2 types of cognitive training that have been studied and that I'll discuss these studies this afternoon are direct instruction within a classroom setting or computerized cognitive training program. And I'll talk about studies that look at these 2 methods. In a large study that involved almost 3,000 participants who were age 74 and above, these participants were randomly assigned to one of 3 intervention groups. The 3 intervention groups were either memory training, reasoning training, or information processing. And that was in a direct instruction with an instructor within a classroom setting over the course of 10 sessions. Or they were randomly assigned to no contact group. 5 years later, these same researchers evaluated the research participants and found that those participants who were in the reasoning training group actually showed less functional decline in their instrumental activities of daily living. So they showed less decline in their ability to manage their medications and their finances and manage their household duties. Interestingly, even 5 years later, the cognitive training resulted in improved cognitive abilities for that specific ability trained. So those who completed the memory training still showed an improvement in their memory 5 years later. Those who trained in processing speed showed an improvement in their processing speed 5 years later. So we're seeing some maintenance gains even 5 years after the conclusion of these interventions. Now, a different kind of method of cognitive training is a computerized cognitive training program. You might have all heard of Lumosity, which is a very popular kind of program that you can subscribe to for about a year. And during my postdoctoral work at UCLA, I was able to be part of the clinical trials that collected data for a different program called Dakin. Now, I have no financial disclosures. I was working as a student, and I was luckily I was part of the team that was able to publish a paper, and we published a paper in 2013 on the clinical findings of this program in the Journal of Geriatric Psychiatry. And so this particular computerized program actually looks into 7 cognitive domains such as memory, attention, critical thinking, processing speed, and you can think of it as just putting all these activities into a 25-minute session that the individual can do on a daily basis. It actually tailors to that person's performance, so if they did great, the next day the computer program will be a little bit more challenging. If they didn't do so great, the computer program will actually be a little bit lighter on them. But the findings of this computerized cognitive training, I actually drove to Laverne and to Riverside because we collected data on healthy individuals who are living in independent retirement centers in Laverne and Riverside. And for the first part of the study, individuals were randomly assigned to an intervention or a control group, so a wait list group. So for the first 2 months, the intervention group were able to participate in these Dakin sessions, and they were encouraged to do about 40 sessions in the course of 8 weeks, so in the course of 2 months. After 2 months, participants were then encouraged to keep playing as often or as they wanted until 6 months. So at the end of 2 months, even those who were in the waitlist group were open to participate in the Dakin program. And then we did neuropsychological evaluations at baseline and at 6 months. And what we found is that there was an improved memory and language performances for the intervention group. Specifically, the higher or the more sessions or the more exposure to these brain or this computerized program, the more sessions actually resulted in higher performances in memory and language at the 6-month follow-up. Those who chose not to play at all actually showed a decline in their verbal recall at 6 months at that 6-month follow-up. So the effectiveness of cognitive training programs. The question is, are they helpful? Well, we're more likely to see improvement in memory with longer exposure to that training program. The findings that we just reviewed actually showed maintenance gains for up to 6 months or even as far as 5 years. And it's important that there were memory training, that the memory training was found to be effective, controlled to those who were on a wait list or a no contact control group. So the bottom line is doing something is better than doing nothing at all. So Dakin and most memory training programs actually focus on these strategies by using fundamental techniques. And we're going to practice these techniques. These 3 techniques really help to make information meaningful and relevant by these simple 3 steps. And that is, number 1, paying attention, 2, using associations, and 3, using visual imagery. And we'll just do an exercise to provide an example of how these 3 steps can be used to remember something new. So I actually mentioned that I did some of my postdoctoral training at UCLA after I left Loma. So my husband actually graduated from medical school in 2007 and went to UCLA for his residency, and I followed. And we spent a lot of time at UCLA for our clinical training, but when we weren't at UCLA, we spent much of our time in Santa Monica. Now, Santa Monica has several of these multi-level parking structures that we would park at frequently. And the interesting thing is that there were several of these parking garages. They were all on the same street, just blocks from each other, and they all looked alike. Now, I'm not exaggerating, and I use this as an example because memory issues can occur with any age. We were in our mid-20s, and we lost our car several times because not only were we in the wrong level of the parking garage, we realized several times just within months of moving there, we were just in the completely wrong parking garage. So I use this as an example because paying attention is important for memory and important at any age. So let's try this exercise because it's meant for parking, because as you can see, that can be an issue for anybody. So let's try this exercise of pretending that you are parking at a parking structure. And the first basic strategy of memory is paying attention. So the idea of paying attention really comes down to looking around and noticing those landmarks. You know, is there a level and an area? Like, let's say that level and area where you've parked is level 3B. Can you come up with a visual imagery of a certain object that starts with the letter B? I'll just take any. Yeah, 3 butterflies. Yeah, I like that one. That would be my first one. Anyone else? 3 bears. Yeah, you get the point. So it just takes 5 seconds, but look around, come up with a visual imagery. The second step would be come up with a visual imagery, like 3 butterflies or 3 bears, and then pair it with that item that you want to remember, such as with your car. Just again, takes 5 to 10 seconds, and you all get the point, but here's just an example. And if you just pair it, and the times that I've actually used this strategy, I've been successful in finding my car again. So again, the 3 steps of basic memory training is paying attention, 2, make a visual imagery, 3, associate or pair that visual imagery with what you want to remember. Now, difficulty remembering names. Can I show a show of hands of anybody who might have difficulty with this? It's quite common. And again, this can be regardless of age. Difficulty remembering names can simply be due to not paying attention or because that name doesn't have any relevance or any meaning. So the idea of trying to use memory techniques to try to remember someone's name really comes down to paying attention and attributing meaning to that name to make it more memorable. So the next time you meet somebody in a social setting, you can try to use these techniques to rehearse that name to yourself. I've kind of started learning, I actually know for a fact that when someone introduces themselves to me in a social setting, I'm totally not paying attention. So the first step is to try to pay attention and try to rehearse that name to yourself. I often have to ask that person, can you repeat your name? And that's very socially appropriate. So if you didn't catch that name the first time, go ahead and ask them, can I have your name again, please? So let's say you met a new person with the name Sandy. So that first step is paying attention. The second step is to create a visual imagery that can be associated with the name. So Sandy can be related to, like let's say I met someone with the name Sandy. I can try to pay attention to that name. I can repeat it, nice to meet you, Sandy. Or if I didn't get it the first time, I can always ask her to repeat that name. So, I'm sorry, can you repeat your name again, please? And then I can take a few seconds to try to come up with a visual imagery that is associated with her name. So, such as Sandy Beaches. That's really easy, and that's actually my happy place. So, it would actually be much more memorable to remember her name. Or, there are other strategies. You can associate that name with someone whom you know who shares that same name. So I had a high school teacher whose name was Sandy. I could come up with that association. Or you can think of someone famous who has the name Sandy. And I think there's one of the main characters in the movie, Grease, was the name Sandy. So there are different strategies, but the bottom line is to pay attention, use visual imagery if you can, and make an association. So what are the overall conclusions of the literature that we've evaluated and just discussed this afternoon? The bottom line is to encourage your patients to be active. We know that lifestyle factors can help enhance cognitive reserve and maintain cognitive functioning even into old age. And what I like about these studies is that it just really shows how much control individuals have over our cognitive health if we are just active. We found that physical fitness can protect against hippocampal volume loss and brain atrophy. We found that cognitive activities can actually help in preventing memory decline over and above physical fitness. These cognitive activities can be simple activities such as reading the newspaper or doing crossword puzzles or participating in discussions or even Bible studies. Cognitive training in classrooms and computerized programs can also be effective. And like I said in the beginning, Loma Linda is not new to the idea of lifestyle factors in promoting healthy outcomes. And again, what has just been so exciting being a part of Loma Linda, being from Loma Linda, is the fact that neuroscience just in the past 10 years has started to show the importance of lifestyle factor in promoting cognitive health into old age. So I just wanted to reach out if there are any questions.
Thank you very much, Dr. Dye. And we will have some time for questions. I have a question for you. I have a lot of very accomplished older patients and come into my office and feel like their memory is declining a bit, and we give them the MiniMental status exam. Perfect. 30 out of 30, right?
Yeah.
Is there a way that you as a neuropsychologist can help me to determine if this very highly functional individual really has an issue with their memory or not?
Yeah, I still see individuals who might have, even a 27 out of 30, and sometimes these patients may just need kind of some validation from us as their providers, saying that there is just going to be that normal change in all of us, and simply, even if we might experience that difference in ourselves, doesn't necessarily mean that it's diagnostic. But if their concerns continue to persist, I'm still happy to see them as a neuropsychologist and spend that several hours with them to help them, to show them the data and say, listen, all your performances are within normal limits and you're doing what you should be. So, I see a lot of healthy individuals, and they still get a lot of validation when they spend that time with me.
Just recently, I heard a lecture that claimed that age, your DNA, your racial origins, cholesterol are not as important as your gut bacteria. Could you please comment on that? And then my other question is maybe commenting on the degree of recovery or improvement of brain function in the senior population. Is the brain still capable of teaching new tricks to an old dog?
Well, I'll address your last question first. And yes, there really still is a large capacity for the aging adult to learn new things. And so, like the studies demonstrated, just being socially active and cognitively active and physically active can do a lot in maintaining one's cognitive health over time. With the first question, I will have to defer since that is not my area of expertise, but I do believe I've been studying the schedule. I think that will be a talk. If it hasn't been a talk already, I think there's going to be a talk with that topic on Sunday.
Yeah, thank you for that helpful information. It was particularly interesting to learn that the brain volume can increase over time, because typically we always see the trend of it decreasing over time. So that was a fascinating study. But my question pertains to cognitive training. You went into cognitive training for memory, and I'm curious, could you go into a little bit more about the cognitive training for both for reasoning and for speed of processing? What's the process there, just briefly?
Yeah, so reasoning would be kind of abstract reasoning and using judgment skills. The processing speed is interesting because just with aging, there is a normal decline of processing speed tasks. So the training for that would just involve doing tasks that are timed and trying to get better at it. There's been theories that the age-related memory concerns are all due to information processing speed. And so, there's kind of a slower retrieval information. So I think that the training program specifically focused on maintaining one's processing speed abilities.
Okay, so they're like time tasks, and you have to work on
all times tasks.
And for reasoning, it's pertaining to judgment. I would think that a lot of people who are older, they've already got that down, the judgment part.
Yeah, that is interesting. I think that would be more of like using verbal abstract reasoning between concepts. That's kind of part of the IQ test that I give. But what was interesting in that study that we discussed is that reasoning course actually showed less functional decline. So maybe they had better strategies in managing their medications or their finances and so forth.
I was curious, are there any relationships between onset of Alzheimer's and other sorts of conditions like epilepsy that you've seen in your research?
Not that I've seen. I will say, and I don't mean to add into, I mean, there are certainly some things that can increase one's risk, other medical conditions, such as a history of traumatic brain injury. That's completely set aside from the concussions, and I don't mean to add into the over-concern of concussions that we've had, but there are certainly other conditions, such as a previous history of traumatic brain injury that has been shown to be a higher risk factor for Alzheimer's disease later on.
Hi, thank you again for your lecture this afternoon. For those of us in primary care, I'd like to see if you could comment on some of the other screening tests that are out there besides the MiniMental status.
Yeah.
And which ones are useful and why?
You know, I prefer to use the Montreal Cognitive Assessment. That's what I use in my own practice. It's the MoCA. The reason why I like it is because I feel like it's a little bit more sensitive, and there's just a variety of tasks such as the clock drawing and trail making that I think are very informative. The interesting thing is not a 1-to-1 ratio. People who actually can do so really well in the MiniMental status don't do so well in the MoCA. And so I tend to use the MoCA, and I only use it kind of as a communicative tool to other providers, but then there's all the cognitive data that I have. But personally, I prefer using the Montreal Cognitive Assessment. Yeah, you're welcome.
One more question here.
Yeah, the people who ace the MiniMental and they're looking for something else to do, they can always do the lifestyle stuff.
That's true. That's very true. And they can do the crossword puzzles and the Lumosity or Dakin. I mean, there has been an increase in the market for that in the past past decades.
So now I know if I'm a patient and you want me to give me the MoCA, I just ask for the MiniMental status exam because we want those high grades. One more question here.
Yeah, this is kind of a question about speed related in terms of memory.
Sure.
Watching like Jeopardy on TV, you'll see a question with a clue. There is a certain speed of recognition that you know the answer,
Right.
followed by a length of time until you're able to retrieve it out of memory.
Right.
At least for me personally, it seems that this speed of recognition that you know something seems to be very, very fast compared to the speed of retrieval. Do any of these tests differentiate between those two? Because certainly the mind has to be recognizing or referencing some list somewhere that you can recognize so quickly
Right.
that you know something before you can retrieve it.
Right. So, you bring an interesting question because there are different stages of memory. There's the learning phase, there's that recall phase, which tends to just slightly slow down as we age. And it really is that retrieval process that kind of slows down. And then there's that recognition portion. And now that recognition portion is the easiest because we know if you ace that recognition portion, we know that the information is stored. It just takes a longer time finding that information. So I think that helps to demonstrate how well you've really analyzed the speed of processing of which when you're watching a Jeopardy game. And that's because recognition is that instant recognition of that information is stored versus that spontaneous retrieval, which can be a little bit slower as we age. But you're okay. If you know that information already, if you can recognize it right away, you're okay. When we know that information is stored.
Thank you very, very much, Dr. Dye. Let's give her a round of applause.